Alrighty, we'll get the intros going. So thank you everyone for coming to Grand Rounds today. My name is Samir Raza. I'm filling in for Khalid, who's away this week, and I'll be introducing today's speakers. So I'd like to welcome Dr. Gladstone and Dr. Kanani from the Palliative Care Service. They'll be speaking today about a draft framework for inpatient palliative care. The two of them are the co-heads of service for the palliative care service at HHS. So a little bit about Dr. Kanani. She graduated from the University of Birmingham in England. She completed training in England and Australia before immigrating to Canada and completing her family medicine training at the University of Toronto. Uh, since 2014, she's been a staff palliative care physician on the inpatient service at the Juravinski and has been the co-head of service since January 2023. And Dr. Gladstone completed medical school at Queen's and her family medicine residency at the McMaster Community-Based program. She spent her first 10 years of practice providing comprehensive family medicine in a group practice, as well as specialist palliative care in a home, hospital, and hospice settings as part of the Brantford Palliative Care Outreach Team. And as I mentioned, she's also recently taken on the role of co-head of the service. So thank you very much for the two of you presenting today, and I'll hand it off.
Thank you so much, Samir. Thank you, everyone, for joining us this afternoon. Our title is very wordy, but what you've landed in is a discussion about a new draft framework that's coming out to guide Ontario hospitals in providing inpatient palliative care. And as Sabra and I were getting ready to present this framework landed in our inboxes multiple times, as I'm sure it ended up in many of yours. And we were all encouraged to review it and offer feedback about it. But it was a fairly daunting task because it's a 60-page framework with all kinds of information. But it applies to all of us, no matter what we're practicing in and what our role is within the hospital. It talks a lot about multidisciplinary work in taking care of people with critical illnesses and serious illnesses. So we thought it was a great opportunity to give this information to you and share it with you, and look for feedback about what is HHS doing great and beautifully with palliative care, and where is there room to grow, and where are we going to go as this framework becomes finalized, and what are we dreaming about? So, Sabra, if you want to go to the next slide. I will give you a bit of information on what this Ontario Palliative Care Network is. So it's a partnership of community stakeholders, healthcare providers, systems planners that have worked together to develop a standardized approach for delivering hospice and palliative care services in Ontario. This group of people is funded by the Ministry of Health and was initially launched back in March 2016. They have released a few different frameworks. One has been in place since 2019 and has been guiding outpatient palliative care for a number of years. The one that we're going to look at today is a model of palliative care for adults in the hospital setting. There is also some work on a draft pediatric palliative model of care that will be coming out. We are going to run through all 12 of these ideas and goals that the framework outlines. So we will get to those. Be patient with us and we'll take you through one by one. Next slide. As we go through this, it seems like a lot of information, and a lot of it I think we're doing very well at HHS already. A lot of it seems like very lofty goals. These are not necessarily mandates or things that we have to ascribe to, but the framework specifically says the hospital model of care is meant to be both aspirational and realistic, describing an ideal state that's achievable across the province in the near term. So bear this in mind as we run through things. It aims to provide clarity for members of an interprofessional team, identify and streamline the process of care, especially transitions in and out of the hospital and between different institutions, and identify opportunities to create and/or strengthen support for interprofessional teams to provide high-quality, person-centered care in Ontario. There were a few definitions that I thought this framework really described beautifully, and will help you understand the model a bit more as we go through each of those 12 different categories. So I want to share them with you before we before we tackle those 12 topics. And this is lifted right from the framework. And I think it's a beautiful way to be looking at palliative care. So, palliative care specifically, they're defining as an approach that improves the quality of life of persons and their families living with a serious illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. Palliative care itself should provide relief from pain and other symptoms. It should affirm life and regard dying as a normal process. It intends neither to hasten nor postpone death. It integrates the psychological and spiritual aspects of care, offers a support system for persons to live as actively as possible until death. It offers a support system to help family cope with the person's illness and their own bereavement, uses a team approach. It should enhance quality of life. And most importantly, it's applicable early in the course of illness in conjunction with other therapies that may be intended to prolong life. Another term that you're going to hear during this presentation, and I think we often use it collectively when looking after our patients and talking about options for management going forward, is a palliative approach. They define palliative approach as care that focuses on meeting a person's and family's full range of needs, physical, psychological, spiritual, at all stages of a serious illness. This approach to care should reinforce a person's autonomy and right to be actively involved in his or her own care. It should strive to give individuals and family a greater sense of control, and it should enhance quality of life throughout the person's illness or the process of aging, rather than just being seen as a discrete service offered when the dying person is no longer having treatment that's effective for their illness. Again, like I said, this document applies to all of us. It talks a lot about interprofessional care team. It talks a lot about a core team, which in the hospital would be led by your most responsible medical professional, whether it's a nurse practitioner or most responsible physician. And then there's circles of care that kind of come around this core team, including a palliative care specialist and other extended services that may come in and out of this person's journey, including nurses, specialists, social workers, psychologists. So, without further ado, here are the recommendations from the framework. Number one, and I think this is where we have some exciting work to do, is identifying patients earlier in the illness and starting to introduce palliative care and a palliative approach to care, potentially even while they're still having their active treatment of their serious illness. The model suggests that we need timely identification of patients who would benefit from a palliative approach to care. Right now, we often react to their critical illness and start to offer this approach, but this should be something that we are foreseeing and starting discussions about early. We need to implement standardized evidence-based tools to identify patients earlier in their trajectory. And once they're identified, healthcare teams need a systematic approach to screen for urgent and unmet needs. Families should be educated about what is palliative care, what is a palliative approach to care, what it is, and what the benefits are to it. And more daunting, it would be excellent if there was some sort of electronic platform that allowed us to share information about these patients as they transition from site to site. Palliative care needs to be comprehensive and holistic. Once we identify unmet needs, they need to be met through sometimes urgent intervention. Care teams need to reach out to palliative specialists if they need support. And we also need to discuss the role of SDMs with patients as soon as we're starting to bring up these conversations. The SDM should be identified and documented, and every effort should be made to connect with patient and family or care partners with formal interpretation services. Hospitals would benefit from trained healthcare professionals responsible for conducting thorough and in-person assessments and be available to mentor and support each other in developing some of these skills. Here we are again with interprofessional team-based care. So we're going to have our core team that is doing a lot of this daily work that's starting to introduce the idea of a palliative approach to care, that's beginning conversations, that's involving the bigger circles of social workers and physiotherapists and psychospiritual care. These people will come in and out of their circles depending on the patient care needs. Um, And additionally, people with palliative care needs and their teams should have support 24 hours a day, 7 days a week for managing their needs. In cases of escalating or complex needs, the core team that's managing these day to day discussions may need to collaborate with palliative care specialists. Palliative care specialists will participate in a consultative capacity with potential for shared care or takeover role, depending on the hospital. Certainly, a palliative care specialist should become involved when symptoms remain uncontrolled. There's specialized interventions that are required, complex syndromes or comorbidities that require specialized expertise. There's complex distress. There's complex social conditions. There's difficult goals of care. Patients keep coming in and out of the hospital with distressing symptoms.
Okay, so I'm going to walk us through the rest of the kind of recommendations. So the next one is goals of care, ongoing assessment of needs, and care plan. And here we talk about the core team or the palliative care team, if they're involved, having discussions with the patient, their SDM, and family members to explore their wishes, values, and beliefs. And then a goals of care discussion will be had, which is realistic in the context of the patient's prognosis and limitations of medical treatment. And this will be reviewed regularly in the event of a change in the healthcare status. The core team will then collaborate with the patient and the SDM, as well as other members of the interprofessional team, to develop and maintain an up-to-date care plan, which I think we're doing, but I don't think we necessarily call a care plan here at HHS. And these will include specific elements of treatment aimed at meeting the holistic needs of the patient. And then this will be available to the patient, SDM, and the interprofessional team through a single EMR. A dedicated member of the core team will ensure that each element of the care plan is implemented by the most appropriate provider, and the member of the core team will be assigned as a primary contact for managing, documenting, and updating this care plan. We then go on to care coordination and care transitions. So again, it talks about a member of a core team who is most responsible for care coordination, and they will be a key point of contact responsible for organizing care and services, liaising with other healthcare providers, and managing care transitions. And they will be the one to facilitate seamless communication between the core team and all the other extended service providers involved. And they will communicate as well with any receiving community, facility-based team, or primary care team to ensure that everybody has a cohesive understanding of what the patient's condition is and what the care plan is going forward. They will also engage the patient and family in transition planning, including a development of a plan and complete medication review. And the family, when needed, will also be offered education and training to make this care plan seamless. And for patients without a primary care provider, a referral will be made to community primary care. So a lot to consider there. Then we talk about management of pain and other symptoms. They talk about use of standardized screening tools to regularly reassess symptoms. And then the MRP collaborating with extended service providers such as physiotherapy to assess pain mobility and all other kind of extended service providers who may be needed. The MRP may also seek consultation from palliative care specialists when needed. The bedside RN or RPN will be very much be part of the team in assessing, monitoring, and managing symptoms, and will consult with the MRP if they feel that there are symptoms that are uncontrolled. The core team will consult with extended service providers to address specific symptom management needs. The pharmacist will also be involved to complete a medication review on admission and before discharge, and will aid with kind of medication safety and reconciliation. And kind of going forward, and I think this is really important, we'll use appropriate technology-based services such as telemedicine, video conferencing, e-shift to kind of bridge all the kind of current service gaps that we have. Next, we'll go on to psychosocial care. And this refers to an integrated approach to addressing kind of the psychological and social aspects of the patients and their family and care partners' well-being within the context of palliative care. The core team will screen for psychosocial needs and then engage the extended service providers such as social worker, Indigenous providers, mental health professionals to help meet those psychosocial needs. And the core team themselves will provide psychosocial support to address the identified needs within their own scope of practice. Next, we're going on to end-of-life care. There'll be ongoing discussions needed preferred setting of care and place of death. And again, we talk about the care plan, which should have been kind of started when a patient was admitted. This will reflect what to expect at the end of life, including education about potential symptoms and who will manage each of these symptoms. The plan should include who to contact for symptom management and contain information regarding the pronouncement of death, completion of the death certificate as well. The core team and possibly the palliative care specialist, if they're involved, will collaborate with the patient and the family to identify where is the most appropriate place of death and initiate planning to make sure that the person is in the right care setting at the right time. Family and partner support. Of course, we know the patient isn't there in isolation. There's a big kind of team around the patient, and the family and care partners of the patient will be supported throughout that person's illness trajectory at the end of life and through death and bereavement. They should be the patient and the caregivers should be offered education about palliative care and information regarding resources and supports available to them. The core team and the extended service providers will continually assess all the physical, practical, psychosocial, and informational needs of the caregiver. Palliative care specialists can be consulted when the needs of the family members and care partners are more complex. And the core team and extended service providers will arrange a culturally safe bereavement support and counseling throughout their journey. The framework also places an emphasis on palliative care for Francophones and would like to ensure that conversations with Francophone patients are conducted in their comfort language. They talk about leveraging virtual care innovations to improve access to French language services. And I know here at HHS now we have Vocera, the kind of interpretation service is much more readily available. And they talk about engaging formal interpretation services when palliative care services are not available in French. Next, they talk about palliative care for equity deserving groups. And I think the first thing they do is identify who these equity deserving groups are. So these include Black, racialized, 2S LGBTQI plus communities, immigrants, refugees, newcomers, those with intellectual and developmental disabilities, individuals with low income, those vulnerably housed or experiencing homelessness, those without legal status or lacking OHIP coverage. And they talk about all members of the care team will offer care that's appropriate, sensitive, and inclusive, and that the care team will seek a comprehensive understanding of the patient's unique needs, language, culture, and personal preferences. They will involve relevant members who can be helpful to those individuals, such as religious leaders and spiritual healers. It also talks about the fact that the patients and care partners should have access to health, literate, and inclusive educational materials in their own preferred language. And hospitals should be providing access to culturally safe spaces for ceremonies and faith-based observances. And then finally, I think this was a really important kind of aspect of the framework was broader aspects for systems improvement. So through what do we need to do to achieve competency? The Ontario Palliative Care Competency Framework is there to provide those competencies. And then colleges and universities should offer curricular tailored to those population needs. And then talked about human resources capacity building and education to enhance skills and knowledges in palliative care. And then information systems integration. So having a centralized province-wide patient information system, using AI-based predictive models to identify patients potentially benefiting from early palliative care intervention. And I know here at HHS, we're looking at HOMER as that, deploying digital health tools and data integration to support active health management and improve communication, enhancing virtual care when we can do. Then it looked at service expansion. It talked about outpatient palliative care services being available to ensure that every patient can access a supportive clinic. It talked about having inpatient palliative care beds available for all patients that cannot be transferred to a palliative care unit or hospice if needed. And it looked at enhancing data collection so that there is continuous quality improvement available and identifying what those key metrics are to recognize kind of areas needing improvement. So I think that was a lot of information and we went through it pretty quickly, but we wanted to kind of leave a lot of time to kind of discuss what HHS is doing well based on kind of this framework and where do we see room for improvement. So I think I'm going to stop sharing the screen now just so that we can kind of have a little bit of a discussion and see if anybody had any comments kind of based on the framework and kind of their thoughts about what we can be doing at HHS.
Go ahead, Dr. Dorsani.
Hello, thank you. Can you hear me?
Yeah.
Thank you. That was a good presentation, and thank you for this new development from the Ontario Network. One of the things that I think is missing in a document like this, and amongst other things in other places of palliative care, is there's lots of emphasis on quality of life. And I think that's an important component, but I think many patients that are deemed palliative, they really have a dismal quality of life. You really consider the number of patients that we all see and treat. We know that they have a dismal quality of life because they're in hospital all the time, they're having procedures, they're unable to eat and sleep and so forth. But what I consider more important, and there's some evidence to support that, is quality of dying. And no one seems to address the quality of dying. And this is an issue. And I think I've been using this many years ago. I've been involved in a fellowship in education in end-of-life care in Ontario. And in fact, one of the studies that we came up, which is actually a landmark study, was called the support study, which was published in JAMA in 1994 and subsequently in 1995. And the study actually clearly showed, and the support study was basically an acronym it was a study to understand prognosis and preferences and the risks of treatment. Basically what they showed was that when they looked at a sample of patients, they took a very large sample of patients that were critically ill. And these were patients that were hospitalized. And the first thing they looked at was how these patients died. And in fact, it was quite significant to look at how many of those patients, by the definitions that they had actually come up, which was suffering. So in fact, more than 50% of the patients were suffering when they in fact were dying. And this was sort of the first precedent that was sort of set in terms of quality of dying. So I think we all should be aware that it's not just quality of life, but more importantly, I think, is how they're going to die. So they're going to suffer and die. If we don't come up with certain measures, then no doubt they're going to suffer and die. So the quality of dying, and I think that may be something worth inculcating into this very large document that you have, or in some way to consider that. Thank you.
Thanks, Dr. Dorsami. I think you make a good point. I think in this document, quality of life kind of is interchangeable with quality of dying. I think it kind of talks about the whole aspects for quality of life that includes kind of what their death would look like. And absolutely, I think we should all be having those conversations, right? About what does life look like now and what does time look like at the end for you, and what are your hopes and how are you wanting to pass away, right? For some, that may be home. And then we have to have that conversation. Is that realistic to be able to do it at home? Other people may have a fear of dying at home, and they may want to look at other kind of facilities. And for some people, that may not even be realistic, and a death in hospital may be realistic. And I'm talking about what a death in hospital may look like, trying to minimize interventions as much as possible, right? So I agree. I think when we're talking about quality of life, quality of death and what that death looks like should be an integral part of that conversation. Julie, do you have
Yeah.
anything else to add?
Thank you. That was good. Thank you.
Oh, Julie, I think you're muted.
Thank you for sharing that article. I look forward to reading it. And I agree. Yeah, I wonder if they're just not using the same language, but I think that's really important to look at. I often talk to patients about the part of their life where they're dying as they're still living, but it's the final stages of their living. But I think the way you label it makes it very clear and concrete to patients that we need to look at this, and certainly as healthcare providers. There's a question in the chat. Can I bring this one up? Much of the presentations about palliative care team and about what the palliative care team will provide to our patients. What should the GIM physicians be doing that they're not currently doing? And I want to kind of go over some of the definitions because I feel like it was so heavy that maybe this got lost. A lot of that the core team will assess their symptoms. The core team will make sure their psychospiritual needs are being screened for. The core team will engage different members of the different service providers. That core team in hospital would be the GIM team. So this initial screening, are we meeting their needs, this initial symptom management, this initial care is going to revolve around the GIM team. And this is stuff that the GIM team, I know you have competencies in this and you're doing it every day. When you need to pull in the palliative care specialist is when it's getting more complex, when there's more complex symptom needs, when there's more complex goals of care. So a lot of this core team, this work is for you, and for us all to support each other in. So I hope that answers your question. And I don't know if you have thoughts about that, because to me, as a core team, as GIM, you guys are doing a lot. And I know a lot of these conversations and a lot of this coordinating takes a lot of time. So I guess the question is this something you feel comfortable taking on? Is there a better way for us all to be supporting each other in this?
Like the one thing that's always a struggle is like when consult palliative care, sometimes it's for symptom control, sometimes it's to provide like coaching and counseling to the family. Um, like I find that coaching and counseling, there's a lot of variation in how internists will do it. But when you consult palliative care, I think there's, more consistency. So I think sometimes we're calling a lot for that to help the family navigate that end of life process, which, I feel like sometimes as internists, we just kind of rush through things or, maybe not as patient, and maybe that's something that we could be more of. So it's not necessarily always complicated, I feel like, when we call, but it's just like, we know they'll do a better job. But, for rightly or wrongly, we're calling them.
And I think the document really speaks to just using all the knowledge around you, right? So there's a lot of talk about using your extended care providers, right? So I think although this document seems overwhelming at first, I think it really talks about gathering everybody's specialist expertise and using all members of the team to fill in all the gaps, right? So I don't think it has to be completely and utterly overwhelming. I think what I took out most from the document is really using everybody to the best of their specialist knowledge and ability, and making sure that we're getting everyone around us to do this work so that it doesn't all fall on one person to do it, right? So I think that's really what I gained from that. And really what I also gained is having a very formalized care plan in place. And I don't think we're really doing that in kind of Epic right now. So I think maybe that might be something that we can kind of look into the future. Is there a place where we can put a care plan that really lays out kind of exactly what the care plan is for our patient population, so that we can, it's just a one-stop shop where everybody can look at it quickly, and see kind of what the information is and what we need to do going forward. Because I mean, oftentimes I know that we're all kind of looking through all the various different progress notes on Epic and trying to figure out exactly what the care plan is, what conversations have been had, what's going on, and is there a place that we can put this care plan so that everybody can look at it quickly and easily, and it's easily accessible to everybody. So I think that'll be an interesting kind of thing to maybe take forward in the future.
And two things I could probably comment related to that. So, like, I think a year ago, there was a case where someone came to the ER and the code status was unclear. And so they ran a code when the person was DNR, and that understandably caused a lot of distress. And so that got this discussion going about how do we document and share.
Mm.
So there is work going on to make it easier for everyone to access advanced care notes. So they did make some changes, but if you hover over the code status, it will show advanced care planning notes. But the challenge is no one documents in that note. So if you have a family meeting and you have a goals of care conversation, ideally that conversation should be documented as advanced care planning note, and then that will automatically populate when you hover over the code status so that you don't have to search the entire chart or type in goals of care. So they just made this change, I think, 6 months ago, but it hasn't been like, popularized it yet. And so this is something that definitely we can work on, because I agree, when someone's had recurrent admissions or been in hospital for 6 weeks, it's very difficult to know who said what when. And so this would be one way that we encourage people to document in the ACP form. Um, the second is kind of a question to comment is, I know in oncology, they've done a lot of work in using the serious illness conversation. So how does this framework relate to that? There are some issues in documenting that as well, and that is also being worked out. But I was wondering, how does that relate to this framework?
Um, I think it goes back to kind of the communication and having someone that's identifying that, right? The serious illness conversation is going through what's important to them and what do their goals and values and preferences look like. So the psychosocial part of this framework. So I think it fits in perfectly. I guess the question always comes down to who is the person that should be doing that, right? And I think that will remain a question. But I think it's interesting, just on the topic of your documenting in the advanced care planning, and that'll pop up in there, because there's also a serious illness conversation note that you could fill out that wouldn't populate in there. So I think streamlining which note are we going to fill out and how does our note pop up in our main body and also in the ACP note, because I think this is incredibly valuable, and some sort of info blast. Because if I had known that it will populate into that post or into their code status thing, I would definitely make more effort to make sure my advanced care planning notes are in an advanced care planning note. So we'll make sure we share that with learners, but somehow sharing this with everyone will be great.
Definitely, I'll take it back to that group. One of the ER doctors is sharing it, so I'll chat with him.
Yeah, that's great. Let us know how we can help. And then it just makes me, yeah, what's the best place to put that note? And those serious illness conversations are documented separately and probably contain more information than you need in the ACP. But certainly there's some crossover, right?
Definitely, yeah. So like the barrier to a lot of this stuff is time. I think, like when you have these conversations, I think tend to wait till someone is really sick, because it's very time consuming to have it early in admission. So that's the part, yeah, that's always a challenge, is that, we kind of run through our day, and only when people get sick will we have this conversation, which is, not always the best time. So that's the part I think is a challenge for everyone, in the outpatient, inpatient setting. And to me, it seems to be a root of a lot of the challenge that we face. Um, I don't know if you have any brilliant solutions, but I think this is a big struggle.
And I always talk, when I kind of do my education with the learners, I always talk about like the serious illness conversation guide being like pre-conversation, right, to a bigger goals of care conversation, because you can't really have a goals of care conversation until you kind of understand the patient's values and what's important to them. So ideally, if you know you have somebody with a chronic illness that you're following as an outpatient, the serious illness conversation has already happened as an outpatient when a patient is well, rather than kind of in crisis as an inpatient, because those conversations then take time as an inpatient, and you're more focused on kind of goals of care and code status and kind of treatment plans as an inpatient. But it's important to know their values as an outpatient beforehand, so that then you can tailor those goals of care conversations as an inpatient and come up with a reasonable treatment plan as an inpatient, without needing to go through all of those sorts of conversations. So I think, yeah, kind of as we're doing kind of outpatient work and patients are well, those are the times to really start initiating the conversation. And I know in oncology, they do set aside certain appointments to have kind of serious illness conversations. And maybe we need to be doing that completely, whatever specialty we're in, whatever subspecialty we're in, right? Setting out those times to have those serious illness conversations, as we're expecting patients are going to decline at some point.
Yeah, I wonder if some of this will fall into the early identification of people, right? So identifying those people early in their illness before they might be suffering, before we have to make these big decisions, and just starting to drop little bits of the conversation into daily interaction, so it doesn't end up becoming one big conversation, or so they're starting to think about it. So I think the framework in saying we need to address psychosocial needs, and we also need to identify people earlier, if that will allow some of this to become, I don't know, it may become more streamlined, or helping people to make some of these big decisions ahead of time or be prepared for them.
Julie, do you want to talk a little bit about Homer potentially kind of in that?
Well, I wasn't going to open that kettle of fish, but I was going to. Maybe we can get to it. I don't know if we're quite ready to talk a whole lot about it. The one thing I was going to say is with this group of people here, if you do have some interest in kind of looking more into how this framework is going to help HHS, or if you feel passionate about kind of moving some of this forward and working together to be a force for education and change within HHS, please reach out to me, because we've started a brand new palliative care council, and we have some groups that are taking off looking into education and quality improvement. And certainly we're looking for a multidisciplinary approach and people from all kinds of specialties so that we can work together. So my email is available, and I would, if you're interested in joining us, would love that.
With regards to the framework, are there things that you see that would be easy for HHS to implement? Like, some of these are very complicated, but are there any things that you're like, oh, we should do that when we don't do that, and it's not super complicated?
I think Sabra's right. I think looking into some sort of AI or Homer or something to identify people within the EMR will be something that hopefully we can do sooner rather than later. The ease of it, I don't know, but I think it certainly sounds like it's a priority for HHS. And hopefully we'll continue moving forward on that in the near future. So Homer, if for people that don't know, is the hospital 1-year mortality predictor tool to kind of flag people that are at risk, high risk for death in the next year, using a number of metrics. There's a number of other tools out there that I think are all kind of being considered, but certainly something to flag these people early, so that MRPs and core teams and family physicians are at least starting to talk about the fact that they're entering this new stage of living, and is there things that we should be approaching differently. I think having a tool like this will be very helpful, but I think it will also open up all kinds of, where do we go with this? What kind of care do we provide these people? These people still deserve great care and may actually choose very active medical management. And how do we walk this pathway? So lots on the horizon.
No, that sounds very interesting. Dr. Dorsama, go ahead.
Thank you. May I just ask another question? How are we going to integrate this with the communities? Because I think there is an important community education component. Because, whatever we do, if patients and or their families are not in tune with what palliation means and the whole concept of quality of life and quality of dying and how they're going to die, what are we doing and how are we going to integrate this approach with the communities?
I think that's a great point. One of the key concepts in this framework was integrating with community and making sure those transitions go well. So having a point person within the hospital that hand it over to whoever their core team is in the community, so they are aware that these conversations have been had and what patient choices may have been and how to support them and how to keep going. Because you're very right. We see them for this small little snapshot in the hospital, right? So much, most of their life is out in the community with their family physician and their health teams there. So I think it is making sure what happens in the hospital is well handed over to whoever their core team is there.
And then I was going to also mention palliative care kind of as a public health issue. I mean, there's a big drive to make palliative care a public health issue so that it's more talked about. So everybody, regardless of their health status, is thinking about advanced care planning and what the future looks like. So I think it has to be opened up to the community and not just people who have chronic illnesses, who are unwell. It has to be opened up to everybody. And that can only happen kind of out there in the community. It can't happen just with medical professionals. It has to be kind of a change in the culture of a community. And you're right, it's really difficult to do that when a culture is so ingrained. And it's interesting because I've kind of now lived in kind of 3 different countries, Canada, the UK, and Australia. And even kind of within those 3 countries, I see differences in the culture and the expectations of people and what they're willing to talk about death and dying and what that looks like. So how do we kind of change and kind of make a culture that's already ingrained different? I think you're right. It's very, very difficult, and it kind of has to start kind of out there from kind of whether that's kind of the wider community, kind of religious communities, social communities, schools, everybody kind of talking about kind of life and death and what that looks like. So it truly has to be a change that happens within the community rather than just within the healthcare professional kind of network.
I mean, practically speaking, I think I try and either myself or get ward clerk or social work, if I've had a serious illness conversation with a patient, just fax 1 extra copy to the family physician's office so they've got it. I mean, all I can do is try and get that information. And so if I'm not picking up the phone and telling the family physician that we're now at this new stage of living, then trying to get them more copies, which I'm sure they don't appreciate. But, just trying to make sure they've received what they need to know where the communication needs to pick up. And I think we're stuck there right now, right? I think there's lots of change, Dr. Dorsey, that needs to happen. You're very right. And hopefully in the next 10 or 20 years, there's more momentum and things do change.
Thank you.
Could you comment on like when we discharge palliative patients, I'm always unsure, what the role of the palliative care outreach team is versus the family doctor versus the pain and symptom management program. So how do maybe you can give us a little rundown?
So I can speak a little bit to the pain and symptom team. So the pain and symptom clinic is based within the cancer center, and they really see patients who are still under active oncology follow-up and have an oncologist at the Juravinsky Cancer Center, so that they have a very kind of specific focus. If patients are being followed by other oncologists within our LIN, let's say like St. Catherine's, they have oncology follow-up there. Then there's actually a pain and symptom clinic within kind of St. Catherine's within the Walker Cancer Center, and they're more likely to ask that you kind of route the follow-up to those kind of different areas. And then that would apply, I think, throughout the whole LIN, kind of each kind of area within the LHIN, like Niagara, Brantford, Burlington, everybody kind of has their own palliative care team. So kind of wherever the patient is kind of um, being followed for their oncology follow-up would be kind of where the patients would continue to be followed. Julie, do you want to kind of talk a bit to the outreach team?
Yes. So the outreach team, well, my caveat to all of this is if you've done a beautiful job managing the patient and you have not needed any support from us and you are getting ready to discharge them, I love getting phone calls and helping sort through this because I'm going to tell you now, but it's also nuanced and it depends where they're going. So if the question is, I just need to do a referral and I don't know where to send it, please don't hesitate to page us, and we'll help you through or send us an Epic chat. In Hamilton specifically, the outreach team will manage people with cancer diagnoses or non-malignant diagnoses that have a palliative approach to care. It's physician or nurse practitioner based, and they will go into the patient's home and make recommendations to the family physician for symptom management. So they act very much as a consultant. They would do a first prescription for new symptoms, but then would leave a lot of the ongoing management to the family physician. Um, and that's the way it works in Hamilton. So the family physician in Hamilton should be doing a lot of the management is kind of the way it works here. But they can have specialist palliative support through the PCOT team if it's required.
And then
Does
I
that
just wanted
answer your
to, yeah, and I just wanted to flag that oftentimes we're not really looking to see if a patient has a family doctor until kind of right at discharge. So maybe part of what we kind of need to do to make sure that our kind of patient care is improved is right on admission, just making sure that they have a family doctor listed. And if a family doctor isn't listed, finding out if there is one, and if there isn't one, kind of getting social worker on that straight away. Because it does take time to find a family physician, especially in Hamilton. The social workers kind of do have a list of practices that are potentially taking right now, and a list of family doctors who are comfortable managing kind of patients receiving palliative care. But all of that takes time, and if that's going to delay discharges by a week because they don't have a family doctor, and then their care can't be managed in the community, that of course has issues with bed flow. So maybe that's part of also what we need to be looking at right on admission is, does the patient have a family doctor? And if not, let's get on that straight away.
another initiative kind of as far as coordinating into the home that we've been kind of working on at Juravinsky on different floors is kind of a discharge checklist. What does this patient need to have to land successfully in the community, right? So all the medical things they need and all the supplies they need, but do they have the home care and do they have a family physician, and has a family physician received some kind of handover from someone on the team? It doesn't have to be the physician, to make sure that they land softly, and don't come back for things that we could manage in the community. Because certainly when you're at that stage of life, no one really wants to be in the hospital all the time, right? So something we're working on and happy to share if anyone wants any information about it.
Perfect. So, any last questions that you can pipe up? Otherwise, we will bring Grand Rounds to close. So thank you very much, Dr. Kanani, Dr. Gladstone, for speaking today. Really appreciate you taking the time to share with us some plans for the future and get feedback. So we look forward to hearing how the next year unfolds with this framework.
Thank you.
Thanks everyone for your interest.
Bye-bye.
Have a good afternoon, everybody. See you next week.